Let's do it. All right, Kristen, take it away.
Oh, I think I was on mute. Hi, everyone. Welcome to session 4 for our self-measured blood pressure affinity group. Looks like we're waiting for a couple more folks to trickle on, but I'm really excited to see Jamie, Dr. Humphrey, some of my fellow colleagues at Mountain Pacific, as well as Chris and her team from SMBP. So welcome, everyone. We are excited to have you. Next slide. Okay, so let's just do some fun old audio checks as well as some chat as well. We're all, I think, in the midst of summer right now. So what is your pick for summer fun? What do you like to do to enjoy or escape this hot weather? All right, Patty is saying camping. I definitely can agree with that. I think I'm going to have to go with, oh, Brandy said pool with the kids, pool and beach days. Love it. I always have like a special week with my nieces and nephews where they all come and stay with us. My husband and I, we don't have kids, but we've got all of our nephews and nieces. And so that starts this week. And so it's all fly fishing and lake time and just tons of fun with each other. So it's really special. And especially after COVID, even more exciting to have them now that we're all vaccinated and healthy and can really just enjoy all of our time together. So that's my big summer fun. What about Deb? I don't think I saw you chat in. If you want to come off mute, what do you do in the summertime?
And explain what tanking is.
I did respond, but unfortunately it was just to Patty only. So we are going to go tanking in Nebraska. I called it redneck fun. So they have different size stock tanks that you put people in lawn chairs and you just float down the river. So I have never actually done that myself, and I probably might just use that paddleboard instead. But we'll see how it goes.
My brain went to like driving an actual tank in a field, so which also sounds super fun.
That would be more spring or fall thing, you know. I do like the water for summer.
Aaron's fishing, and Joe is time on the ocean. On or in the ocean?
Most definitely. Great. Well, happy to have everyone and really excited that, you know, you can all just get out and enjoy this time. You know, it's definitely one of the highlights of the year for sure is doing these activities. Okay, let's go ahead and go to our next slide. Okay, I think our housekeeping is pretty obvious. We're all good on this front. Just anytime you've got questions, feel free to throw those in chat. You can always come off of mute. As we said before, this is all very informal. We've got Dr. Humphrey, our subject matter expert, and we will have another one that we are introducing here a little bit later on in the presentation. So it's going to be a nice opportunity for you to ask questions. We can assess your needs, you know, basically just kind of get a lay of the land now that we're at our last session. Next slide.
Whoops.
All right. So my name is Kristen Schuster with Mountain Pacific, your MC, I guess, for this whole series. I'm thrilled to have Patty Sednar, who is my colleague here. She works with practices in Montana around cardiovascular disease and diabetes, as well as our reigning expert in quality improvement activities, root cause analysis, and all things technology. So really happy to have her as a co-facilitator for the session today. Next slide. All right, our typical ground rules here. So, you know, assuming positive intent, I know we're all in a little bit of a different place on our journey. We've lost some of our colleagues along the way, but let's just, you know, try and follow these ABCs for our final session of this series. Be here and now. I know this is hard because it's really easy to fall into our multitasking kind of debacle, but try and be here in the now. And then come prepared to share. I don't think it's a mystery of what our format is today. So we want, discussion, collaboration. There are no wrong answers. This is all about a journey and kind of where you're at as in your perspective with SMBP. So we want to hear where you're at, where you're going, and then what we can do to help you out. Decrease distractions and respect time. I do have my dogs locked out, but I can't really guarantee that they're not going to bark at the male person that is inevitably walking up my stoop right now. But I will try to decrease distractions and respect all of our times as we move through the presentation today. And then lastly, everyone teaches, everyone learns. This is my personal favorite as we've gone through this journey together. Next slide. All right, so this is in partnership with all of our regional partners. I am excited to be able to see our Hawaii Department of Health on the line, but there are a multitude of stakeholders that you've seen present throughout this series. So just want to thank all of the regional partners that really made this possible. Next slide. Okay, so what's our agenda today? What are we going to look at? As always, we are going to review our call to action items. Then we're going to look at how to receive and interpret blood pressure data, then an overview of SMBP program implementation and steps, and then start small and use Plan, Do, Study, Act, or PDSA cycles. And then we've got tips from Joe and discussion and Q&A. And then we're going to end with kind of next steps. We don't want this to be an ending of our collaboration or our relationship. It's just the end of this particular 4-part series. We're still very interested and invested in all of the progress that you're making throughout this journey and really want to get a good understanding of, how we can help you all move forward with your particular programs. Next slide. Okay. So over the last, I think you had 3 weeks between our last session and right now. So let's just kind of think about what the patient component was, specifically around education. So what patient education are you the most interested in? Either, that you're interested in finding or developing, but what is the patient education that you're the most interested in? Obviously, they're a pretty darn important part of this whole process. We can't really do self-measured blood pressure without the patient. So what kind of education are we looking for?
I'd like to ask a question of the group, the clinics who are on. Did you go out and look at any of the patient education that was made available at the links that were provided at the last session? I mean, even if you're not ready to start your program, did you take a look at any of them? And do you have any comments on them?
Yeah, hi, this is Jamie from USERRA Internal Medicine. So I really liked the Target BP one-page handout on accuracy, how to measure accuracy, and then the kind of like common pitfalls of not taking it accurately. It's just very simple, not too many words, colorful, and yeah, I feel like it's a good one for patients, easy to understand. So I think that will be one of the probably most important pieces that we're going to be giving to the patients when they initiate the program, alongside the training that they get in the clinic.
Nice, good. Thanks for that feedback.
Patty, I know you've had some experience with, through your blood pressure work, retraining and doing some ongoing education with nurses and care managers about their accuracy. It's kind of one of those things where we'll want it to kind of just start good habits from the source. So then, when you're educating patients, obviously that will continue. Do you want to share kind of what you've heard from kind of your care team members about that?
Yeah, so that's a really good point. So I'm here in Montana, and I work with the state of Montana Department of Health, and they actually, as part of their funding, they were able to provide training for clinical staff on how to accurately do blood pressure readings. And not only just the training, like documentation, they went in, they looked at the rooms, they saw how the room setups were, and gave advice on all the things that contribute to positive blood pressure reading. And, every single time you recommend it or you bring it up, there's always pushback from the clinical staff. Like, we know how to do this. Like everyone doesn't, no one feels the need for it initially. And then they're so glad they went through it. They really are appreciative of going through it. So if it's something that is even like the videos that are available out there, even if you can do that during like a staff meeting, like just run the YouTube video or whatever for the staff to do refreshers, it's always a really good place to get everyone on board right at the beginning with best practices. So we're able to do that in Montana. I'm not sure, maybe Blythe can talk about what's available in Hawaii. And I'm not sure about Wyoming and Alaska.
I think I got on here, Patty.
Yay. All right, Joe, our subject matter expert is on. All right, we're still going through the content, Joe, but I'll introduce you soon.
Okay.
Thanks.
Okay, I just want.
Yeah, I was a little nervous. So yay.
You're not the only one nervous. I'm nervous here because I can't figure out why Zoom isn't working. It worked 3 weeks ago from here perfectly.
Yeah, no worries. All right, Kristen, keep going.
All right, great. So as you kind of continue, I love hearing this feedback about multi-education kind of and engagement strategies with, your care team members, your nurses, your doctors, your patients, and, really making it a widespread kind of cultural change within your clinic about how, these best practices of blood pressure readings, really go, what those standards look like, where the information goes within your EHR. So you have all of the information you can to make really the best decisions possible for your patients and, ultimately, measure the effectiveness of your programs overall. So following this, we'll make sure that we include some of those historic patient education and provider and care team member trainings as a post follow-up. We've got some great partners at the American Heart Association that have some fabulous resources out there. Next slide. Okay, so we've got, I guess, a few clinical folks on the line, but one of our kind of takeaways was, were you able to train one patient in SMBP over the course of the last 3 weeks? And then if no, what can we do to help you out with that? So how has that gone over the last 3 weeks? Have you had some patient feedback? And then, Dr. Humphrey, Joe, if you have some experiences about what your training looks like, please feel free to chime in about what that collaboration has looked like and what your experience is.
For us, probably the biggest thing was to have the physicians. Our biggest training thing was getting our physicians on board and our providers on board first. And once they had an idea what was going to be trained, then they were on board for getting patients referred in and telling them exactly what they should expect and why the physician was asking them to do this with us. It's always about a half-hour session is what the patient, and we have a little handout to tell them what they can expect from that half-hour session. And the physicians were given a thing that told them how many minutes were in each one of these sections as well.
So Joe, you're saying being very clear on what expectations are was helpful for your patients?
It had to be, because then the patient knew why the physician was referring them to it. Because otherwise they were just saying, I'm going to another program. I don't have time for another program. And then we give them rationale why self-monitoring blood pressure becomes the hallmark of, besides pharmaceutical therapy, yes, is there, but the hallmark is how they are going to monitor it themselves. And we did a really good job of selling that to our providers and our MAs and so forth right out of the gate. And then they were able to do that same type of enthusiasm to the patient.
That's great. Thank you for sharing. I know we've got Jamie on the line. If you want to come off mute or chat in, were you able to engage with any of your patients over the last 3 weeks?
Hi, yes. So we were able to do two different patients for training. So one was like an older female, and she was actually with her sister, who kind of served as a caregiver. So both of them were able to do the training together. And then the other was a elderly male, but he was by himself. So, yeah, I guess some of the advantages that we had was that we had the blood pressure monitor, in the clinic, and then the doctor had decided at the visit that he wanted to give it to the patient. So we had the device, we're able to set it up in the office, and then, give those blood pressure logs. And then feedback, I guess. So we didn't formally, enroll these patients into the program yet because we haven't chosen a start date. But after the training was received, 1 week later, I just called back to see if they were using the blood pressure machine. One of them I wasn't able to reach, but the other one had been taking them daily. So she was able to report back the readings and had been started on a medication that day, so was taking the medicine and it was actually already improved. This was 2 weeks later. 2 weeks later after getting the device. So, yeah, that was just kind of like a trial. We haven't really formally started our program, but so far, okay.
That's great. That's great. I mean, you got to start someplace, and it's oftentimes it's easier to just start with a very small subset, so you can start to get your sea legs under you and start to figure out the best way to approach it. So congratulations. That's awesome progress. Great. Okay, well, I think we can continue on. And I think I'm going to pass it on over to you.
All right, yay. So before I go into the next content, I really wanted to talk a little bit about what we've covered so far. So the Affinity Group has been 3 sessions so far, and this is the 4th and final session. And in session 1, we talked about the different models for self-measured blood pressure and the different devices. We talked about staffing, training, and scheduling. Session 2, we talked about patient identification and education, and went in a little bit into the billing. We know we still have some questions about billing, but that was session 2. And session 3, we talked about patient engagement and education. And then in this final session, what we're going to talk about is how you receive the patient data, how you interpret it, and then how you can use very basic quality improvement models to tweak your process to get it better and better as time goes on. So that's what we're going to cover. That's what we're going to cover now. So patient blood pressure data, before you even worry about how you get it, you'll want to think about what information is important that you collect. There's a lot of different tools out there, but what is it that is important for you as a clinical care team to collect? And what information do you feel is important or helpful for the patients? So when you're thinking about collecting data or having patients track it, think about, are there tools that you can increase their engagement and their self-management? Should the patients be averaging their readings? What does that mean versus just a log? And should they keep track of what's happening during the day when they're taking their blood pressure measures? So kind of think about what is the information that's important for you to know when you're retrieving information from the patient. So before you pick what tool it is, think about what you're hoping to know. And then there's a lot of different ways to actually receive the information from the patient. And again, some of these can be customized based on what you're thinking is important. So one way is having the patient complete and return a blood pressure log. So there's a lot of links. I have a link right here to the Target BP patient log. You can have the patient call the clinic with blood pressure. Like, even if you don't have anything in place, you can use old school, just a telephone call, if that's the only way you can get the data. Some patients can use, if you have it available, your electronic health record has a portal, or often secure email is available. You can read the results during the secure telehealth visit. And then some devices interface directly with EHRs. And that's really, you don't have to have that happen, but it's an option that's out there. So there's a lot of different ways of getting the information in. I think the most important thing is deciding what information is needed and useful. And then once you get that data in, there's information out there on how you interpret results to manage your patients. Now, I'm sure you all know by now, I'm not clinical in any way, and I just did a screen print from the American Heart Association Target BP website. But what I wanted, the reason I wanted to put this out here is that you don't have to recreate the wheel. There is information out there already for you. And you may already have a protocol in place that does this, but if not, use the tools that are out there for sure. And so from a high overview, from a high level, these are the steps you need to do to implement a self-measured blood pressure. You choose an approach, whether it's a loaner program or patient-owned or some kind of hybrid. Identify your staff, the scheduling you're going to do, how you're going to document the results, and how you're going to bill it. Purchase your devices if that's applicable. Create your training materials for both the staff and the patient, and identify which patients you want to start with. Once you do that, you can begin your self-measured blood pressure monitoring program. And you don't have to have all these things in place to start, but this is like kind of an implementation plan if you wanted to go step by step. And then once you start, this is kind of the key, what I think is the key to success in anything that you're doing in your clinic, is as you introduce a new workflow or a new policy or some new treatment, you always want to monitor that and make sure that it is in fact as efficient as it can be. It is producing positive results and it's what you are expecting. And you can do that by just using the Plan, Do, Study, Act or PDSA cycle of rapid improvement to do that. So I'm going to just spend a little bit of time on PDSA. That's again, Plan, Do, Study, Act. And it's a very basic approach to rapid improvement. And all it means is you plan what change you want to make or what you're testing or what your new process is, identify what steps you want to do, including how you're going to collect data. Like how are you going to know that it's a positive or negative thing? So how you're going to collect data. Then you actually perform those steps or run the test or make the change. And then you analyze the results and say, did it turn out the way we thought it was going to? And then based on you learn, you tweak it. Based on what the data shows you, you tweak your process. So I think it was Jamie who said, we're not sure when we're going to start our SMBP, but if you just start, like not officially, just start small with 1 or 2 patients, collect data back, analyze the data and say, hey, is this data useful? Are we collecting everything we need? Do we have an efficient process for it? So you can start really small and then just tweak your process as you go forward. And one of the things that I like to talk about when I'm speaking on quality improvement is oftentimes people don't implement change until they like have the whole thing figured out. And the value of the PDSA or rapid improvement cycle is that you can start really small. You can start with like 1 patient or 1 doctor or 1 day and run that through the process, analyze the data, and then rethink it. So it doesn't have, you don't have to have all the answers in place. You don't have to know how you're going to bill it. You don't have to know, wait till you have every single possible blood pressure cuff size. You can actually just start. And then based on what the results of your small tests are, and this is recommendations, I should say, from the Institute for Healthcare Improvement, they recommend starting small. And then if you get the results you expect, go from testing 1 patient to 5 or 5 days or 5 care teams or whatever. And then as you get the results from that, if it's what you expect, then they say to increase in the rule of 5. So then you go to 25. Or 125 or whatever you're comfortable with. But the whole thought here is you can start with what you have now, even though you haven't made every possible decision on it. Because what you're going to find is as you get results back, you may need to change your processes. So that's the part I was going to cover. And I want to see, are there any questions at all on receiving data or interpreting results or the PDSA cycle before we move on to Joe? Any questions? And you can come off mute or you can chat in, either way. All right.
Hi, this is Jamie. Sorry,
Yeah.
I have a question.
Yeah.
Is there any, I guess, recommendation as far as how frequently to get the readings back?
Yeah, I'm going to ask Dr. Humphreys and Joe to speak up on that. Any recommendations?
Yeah, I can add to that. Where we've been using is the Million Hearts, which is very similar to the AMA-AHA recommendations. And I would emphasize that data collection on the patient's part, to be accurate, needs to be very highly structured. And the recommendation is a morning and evening blood pressure. The morning and evening is not clearly defined, but it's basically, in the morning it's relatively easy because it's fairly soon after you get up, which is, there's a circadian rhythm, and the idea of home blood pressure monitoring, or SMBP, is to be able to reproduce and the results of ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring has been a research tool for now 30 years and predicts cardiovascular outcomes better than office blood pressures very clearly. And it's very cumbersome, so we're not going to use ambulatory blood pressure monitoring to manage patients. But because home blood pressure monitoring, or SMBP, correlates well with ambulatory blood pressure monitoring, we want to follow those criteria. So it's a morning and evening reading, either 2 readings or 3 readings at a setting, a minute apart. In one of the webinars I was on, somebody pointed out that even white coat hypertension actually happens when you put the blood pressure cuff on, whether in the office or at home. And so we've been using 3 readings. And if I note that the first reading's always high, why it often has me adjust a little bit in looking at how I manage the patient. And the most recent data, and the data that came from some of the previous research, indicates that that actually the SMBP data over 7 days is a more accurate measurement of cardiovascular risk than getting a 24-hour monitor for just 1 day. You have variation from 1 day to the next, and the more data you get, the more accurate you are at actually predicting the resting blood pressure, which is what predicts a long-term outcome. The current recommendation is now 7 days of data collection, morning and evening, 2 or 3 readings, which if you do 3 readings, well, you end up with 42 readings. That's a lot of log.
Right.
But also that's the best data, and that looks like it's firming up. Million Hearts and the CPT code requires at least 12 readings, which is 3 days, 2 readings each day. Or, I mean, I guess it's 18. But you have to get at least 3 days readings to get the average. Now the frequency is you only have to do that one week. And if the patient's doing well, as if you see a patient in the office and their blood pressure is 120/80 on medication, you might see them back 3 or 6 months later. And that actually could work for home too. The blood pressure doesn't dramatically change unless there's a change in weight or activity or something. So infrequent measures, but getting them really accurately for 1 week would be what we'd want with our patients. And if you're in the management, well, it's really dictated by how frequently you want to change therapy. Automation really helps because then the patient can send the data in without, or you could, have them scan and fax the data in if you wanted to off a patient log. But that really relevant is when does the medication work? But with home blood pressure monitoring, you can do adjustments every couple of weeks because most of our medications work in the first couple of weeks, and we should be able to see whether that specific medication is making a difference or not. So the patient would monitor for a week, as baseline, change the medication, and 2 weeks later or 3 weeks later, get another 1 week's worth of reading and see if the medication's effective, and do medication adjustment until you get towards target. And that's all shared decision making. There's the SMBP really gets the patients involved in making these decisions, and I think you have to emphasize that to the provider and the care team, that they're the ones that have to spend the money on the medication. They're the ones that have to live with side effects. And we can't just keep adding medication without talking to them about, the balance between getting their blood pressure down to where it would be ideal and what their quality of life is. I'll end there and answer any questions you might have.
Okay, well,
The only comment I'd like to add on to Patty is Dr. Humphrey did a really good job. I'm a little more in our program, or a little more, I guess you could say, dictatorial. We make them do about 2 weeks of the twice a day, because we're trying to create a habit for them of when to do blood pressure and how to do it. So outside of that, we do exactly the same thing, the 2 weeks, in case we have to do, adjust medications. But we found that if we went with 2 weeks in our program, they develop a habit. And if we can get a habit of doing it correctly, it helps us out in the long run.
Cool. Okay, I just did want to welcome Cynthia Armstrong, joined us from Northwest Physicians. So Cynthia, thanks for jumping on. We appreciate seeing you. So I covered all of the content I wanted to do. So I'm actually going to now introduce Joe Tabler, who's I've asked to share his experience with setting up a self-measured blood pressure program. Whoops, I'm on my wrong screen. Hold on. So Joe, his real name is Carl, which is why I'm going back and forth between Carl and Joe. So sorry about that. He likes to be called Joe. So Joe Tabler is a clinical pharmacist with Logan Health in Kalispell, Montana. He's the clinical pharmacist that covers 3 clinics there. And the SMBP model that they identified or they're using is a patient owned. So they aren't purchasing them or loaning them, but they're working with patients on their own cuffs. So, and then Joe, the first question that I have to kick off was your recommendation. So if you want to ask this next question of the clinical folks on, that would be great.
Okay, I'd like to start the whole thing off. You have to figure out, what do you really want to have for your outcome? What do you want your program to be? We set ours up in one way. We knew what goals we want to get patients in target range, and we also want to take some of the load off of our providers from doing all of the med adjustments and doing all of the follow-up. So that was one of ours. And so before you start off, make sure you know what outcome you're trying to get to. Sometimes that outcome may not be what you've expected by any stretch of the imagination. So make sure you know what your expectations are from your program. And then we want to make sure, and I'm going to leave it at that one. I think Patty's got the next slide probably there about what I had said. How we go about selecting our patients is patients have to be able to afford or have access to their own cuff. And there's some people that just cannot operate a cuff. Unless they've got a caregiver that's with them that can help them out, they're not a good candidate for self-measuring their blood pressure. And they also have a communication device. In our area, there's some people that live out in the bush, and we see them once every 6 months, usually when it's a disaster of something happening. That's the only time that we see them. So those are not good candidates as well. And they must have had an elevated blood pressure on their last 2 visits before we get them involved with us. Because they can have an elevated for a number of reasons when they come into clinic, and we just want to make sure we've got 2 elevated visits before we spend the time, effort, and also get them to spend the effort working with us. Documenting our results are always documented by the telephone, and we always want to document when we did a validation on their cuff. When a person buys that cuff or gets one given to them by somebody, we always want to make sure that cuff is one that is measuring right out to what our AOBPs in one of our clinic are getting, so we can actually get to the point that we're getting good, accurate results.
Joe?
Yep.
Yeah, so when you say you get your results via the telephone, can you talk through that a little bit?
Okay. Telephone, our best bet is when we're getting the patients, we get them to phone in results every week. Because if we go more than every week, they have a form that we give them and we ask them to basically write down their systolic, diastolic, the times a day they've done it. And we also have on that form, is there anything that's caused you a lot of stress? Have you had any of the offending substances that may have raised your blood pressure, like caffeine, nicotine, alcohol, any of those things in the last hour to 2 hours before you did your blood pressure? So we always ask those ones, and then we get them to communicate that back to us, and it's always via the telephone. They will phone in, and they'll usually phone in to myself, and I'll put that into the chart. We email, our biggest issue with email is confidentiality on it. If we had a better way of doing it confidentially, I think we could use that one, but we've stuck with telephone because we think that's probably the most confidential way that we can do it to get that information back to us. Does that answer your question, Patty?
Yeah, thank you so much.
Okay. Okay, one of the things that we really had to work on was getting our providers on board. At first, they were a little bit, well, when they come in, we do a blood pressure check and all the documentation was out there. So I pulled in a bunch of stuff that showed that self-measured is a far better way of getting a proper diagnosis of it, of hypertension in the patients. And so we worked with them. And then suddenly, when the little cheat sheet that I mentioned before came out that showed the provider exactly what it was going to be like, suddenly we were getting a fair number of people referred to us, to the point right now that we get from providers, I am seeing at least 4 to 5 a week right now that we're getting involved with doing self-monitored blood pressure, basically to either adjust medication or else work with them then as well on lifestyle modification that will help out their blood pressure. One of the things I want to hit on is the patient outcomes. When we went into it, we thought that outcome was going to be, the best thing would be to get blood pressures within target range. Unexpected outcome for us was that I've spent a fair bit of time as well talking about when we talk about what affects our blood pressure, we talk about lifestyle modifications that they can do. Not only is affected blood pressure, but we're also enhancing their mental health. We're also helping out other health incomes like lipids and so forth. And when we've dealt with these patient outcomes, the ones especially when it comes to lifestyle modification like exercise, meditation, any of the other things that we like to tell them that will help out blood pressure as well, those have been an unexpected outcome that have come out of this, is that the people are grabbing on to the lifestyle modification side, and that was an unexpected outcome. So our outcomes have been very positive overall. Patients, when they take ownership of that blood pressure, it becomes theirs. And when it's something that they have got something that they can modify of their health and their own, they suddenly want to do it. Like when Dr. Humphreys mentioned the twice a day blood pressure monitoring, it seems onerous at first, but when you explain to them that it's for their own well-being and they're actually going to be taking control, and we may be able to even reduce medications eventually, well, then that gets their attention, and that was the things that they will come on board and they'll go from there. Some of the things we've learned, we've learned a lot in the last 3 years doing this. And the things we've learned is patients have to be taught about what is, everyone will say that a blood pressure cuff is expensive, but we have to put it in perspective of what an investment in their health is. And that's what we've got. We've got a little tip sheet I hand them out. This is an investment in your own health. This is investment in yourself. So again, those are the things that we have learned from ourselves. And we've done a very good job of getting providers on board. And that is your primary place. Get sure your providers are on board, and that if they promote it to the patient, it will be a successful program. Billing for this system, our health system has decided they did not want to bill for it. They said the amount that we could get for it wasn't worth the effort to put into it. So again, thus far, we've been fortunate. We've been able to work with our CPC plus monies and so forth. And we've had this as an outcome for our patients, as well as some grant money we've been working with to get patients involved in this. So again, make sure you talk to your organization, find out if they're willing to invest the time, effort to come up with a billing code. Some of our situation with that as well is that we have to put people in as providers into it as well, which becomes a problem with our system. So again, that's what we're working at with ours right now. Like I say, the lessons and tips I've learned have been a lot. I could spend probably, I sent in Patty 2 pages and I could expand to about 3 on each one of them. But again, every organization is different and every patient is different. And make sure that you, when you're going to do it, that you do a good educational portion. Like ours, we've targeted to 30 minutes and they make sure they bring in that blood pressure cuff. We work with them, give them the information they need, make sure they do one with their own cuff with us, that we feel comfortable with what they're doing. And then we tell them how to go about doing it and get them rocking and rolling at home. And then some of them we have to handhold, others we don't, some take off really well. So again, we have to make sure that they're on board and make sure the rest of the staff are on board, because eventually after the first couple of weeks, we get MAs taking the blood pressures and writing it in when they phone it in as well. So I handhold them for the first couple of weeks. And then after that, we get the whole team involved. And with that, I think that pretty well covers most of what I had in there, Patty.
Yeah, Joe. So we're working with Joe under the Department of Health funding here in Montana. And one of the things that you're doing is you have created what you call hypertension clinics, where it's a day in the clinic. So would you share a little bit about how this can lead to something like that?
Hypertension clinic was a thing we came up with as one of our innovative things. And a hypertension clinic is one where a patient can come in and free of charge, they can have their blood pressure checked, have their own blood pressure cuff validated as well. So we advertise that to providers. It's in every one of the examining rooms. Patients can self-refer as well. So if they want to have their blood pressure checked by somebody that doesn't, and it doesn't cost them for a visit, they can make an appointment, they come in, they get the blood pressure done, and they bring in their cuff. And that is where we ask them the question, what processes are you doing and how are you monitoring your blood pressure at home? And that's where we get some of our people involved in it too, is when we have those ones who are self-referring, they see it and they're concerned about their blood pressure. To go along with that, we also had a blood pressure 101 class prior to COVID. We had those as a group class. We had people come in, listen to how they would do a proper blood pressure monitoring, and then offer them the fact that we could work with them for those first couple of 3 weeks to get them going as well. So again, those are the areas that we've worked with that were a little more innovative than some of the others. The self-referral did bring us in a fair number right out of the gates as well.
So when you say self-referral, you mean patients then that you identify to be part of the SMBP program?
Patients can actually, like, they refer themselves to the blood pressure clinic, and then we can ask them if they want to be involved with self-measured blood pressure. And then we tell the provider that we're doing this, and we provide the provider always with the information on that rotation. They report every week, but we make them go for 2 weeks and they're getting their full reports of daily blood pressures as well.
Great. Thank you, Joe. Great information. I'm going to open it up to the people in the audience. Anything additional to add or any questions that you have of either Dr. Humphrey or Joe? And it's really, this is like our last get together. So if you have any lingering questions or topics you want to cover, we have the experts on the line. So I'd like to open it up to all of you to ask questions of these two experts here, or just share what you're doing as well.
I'm going to just say one other comment. It may seem like a lot of work getting this going, but as a frontline healthcare provider, there's nothing as gratifying as actually seeing people take hold of their own health and want to improve it. So yes, we're investing time and effort, but boy, the gratification you get from people who change is, you can't put dollars and cents on it.
I love that. Those feel good stories definitely are something that I think is well worth sharing, you know, to the care team as a whole, which I would just ask, Joe, how do you, you know, I hear provider engagement, care team engagement is a barrier to some of the clinics that I'm working with. And, you know, how do you share those success stories with your team?
The team gets to know it because we're the one clinic where we're really pushed this is only about 7 providers. So you have a lot of one-on-one and there's a lot of back and forth. And in the teaming room, it really works well if you talk loud enough. All of a sudden, one provider hears what's happened with another one, and they hear back and just work together for the best outcome. We also send out little notes to one another saying how things are going and so forth. And it's just a lot of one-on-one, and the nurse, the MA, and the physician and the provider all work together, and the back and forth is what does it for us. I can't give you there is no formula for that. It just, you got to remember one thing about me too. I'm a very in your face type of guy. When we got something going on, I spread the news.
I love that. I definitely have an in-your-face personality as well, but it sounds like teamwork is like the best way.
It's the only
being excited.
You can't do it without a team. Lone Rangers end up losing the battle. You cannot win it unless you're all working together.
So I guess if while you guys think of your questions, one thing I want to ask you, Joe, maybe both of you, Dr. Humphrey and Joe, like what is like the first 2 things you could recommend to these clinics who are just starting an SMBP program? Like what are the most important first 2 things?
Yeah, I mean, I can take that. Yeah, from our experience, this is unlike most of the changes we make. This is sort of earth changing, and I think Joe referred to that. I'm really pleased that he's the pharmacist. Having the pharmacist as part of the team is one of the models that makes SMBP work. There have been a number of areas, and the Margolis study at JAMA, which was our model, was a pharmacist-based program. I also stress that the team-based approach, and you have to reorient the team. I mean, it isn't just in your office team. It is in the community team, and we added 4 community health workers onto our team to make SMBP work. So probably the first thing is that this is going to take a lot of effort, you know, a lot of changes. The whole organization has to be behind it, and you have to understand the benefit to the patient, which is reduced cardiovascular risk. And we have so many patients with hypertension that we absolutely have to go this direction to really improve health outcomes. So yeah, the emphasis is team approach. It's a lot of work, but the rewards are huge. And I think the other thing that I think was emphasized is really starting small, but you have to be thinking big. And I reflect that we came into this, and I can continue talking to Joe offline sometime, because we've been doing all of this remote monitoring. So there's no patient logs whatsoever, and we've never had patients keep logs. We've always been able to download the memory in the blood pressure cuff. And that's a huge time saver for everybody, and it allows you to manipulate the data. So thinking big and getting to that point makes life a lot easier.
Some of this, and I want to chime in here. One other care team member that failed to put in here is the family member. Oftentimes I'll bring a spouse or a caregiver child that's helping with a patient in, because that becomes part of our team as well. And what Dr. Humphreys is so true. In a previous clinic, in a previous life that I had, we were fortunate because we're in an academic environment. We did have our cuffs that we were able to hand out. They connected straight to our EMR, and they were each given a PIN number when they sent them in, and everybody seen exactly what was going on there. So again, those are really good to have in there. If we can have the system. In our system, we don't have the ability to take the login right now, which would be nice, which would make our life a lot easier. But you use technology to its maximum you can, lever it, because it'll make your life a lot easier.
Well, and I do want to bring up two things. Both of you talked about Dr. Humphrey bringing in community health workers is a great idea, a great support team member for your self-measured blood pressure. And one of the things that Joe does up in Kalispell that he didn't mention, I just know from working with him, is he actually utilizes pharmacy students, interns. They intern in his clinic, and he has them help set up these self-measured blood pressure programs, training the patients, etc. So it doesn't have to just be you. The team can look a lot of different ways. Okay, I'm going to assume there's no more questions, and if there are, please chat them in, and we will certainly ask the subject matter experts here to address them. But I'm going to continue on. So this is the last self-measured blood pressure affinity group program. Thank you for being our pilot project. We were trying to figure out how this might work. And what we want to know from you are what additional tools or resources could we help provide, or would you need to help with your implementation? So if you can think a little bit about what we didn't cover, or what other information we should include in this curriculum, that would help us for the next one. And if you think of something, please go ahead and chat that in, and we'll use that information to try to refine the process. Our own little PDSA cycle. And just so you all know, I know there were a lot of clinics on initially that weren't 100% ready to start with a program, but really wanted to get the overview of it. We will have another SMBP affinity group in the fall. So we've kind of proved out the model. We're going to open it up and include more people on the calls, but we'll do another one. And if you're interested in, if that's better timing for you, let us know, and we'll make sure you get the information on that. So here are the next steps we'd like to recommend for you is continue to develop your process and to identify and recruit patients. Train your staff on what you're trying to do, like train them on accurate blood pressure and train them on how to educate patients. And then identify how the self-measured blood pressure readings will be received and recorded. I mean, if you can do those things, even on a small scale, do a little pilot project, start small, think big. I like that, Dr. Humphrey, start small, think big, and you can get this rolling and then tweak it as you get more information. And then, just like I said, remember, you can start small and you can adjust as you need. And don't let the idea of a perfect or 100% SMBP stop you from taking action. You really can just start. And then here are resources. Again, we'll send out the slide deck, and you can check out these resources. There's a ton out there. Don't recreate the wheel for sure. And then we are going to have a survey, and we're going to email it to everybody who participated in this, so we can try to tweak our process as well. So we'd really appreciate it if once you receive that evaluation survey, if you could respond to that and help us out. And I think, Kristen, anything else before, like, we can open it up to questions? Any comments coming through?
Actually, Jamie chatted in possible for a little more specific, state-specific information on billing codes and details. I said we definitely can look at incorporating that. It gets a little hard just because we have so many states and there's so many state commercial payers, advantage plans, all of that. We do have a billing resource though that I'll make sure that I send your way, Jamie, as well. I think one thing that you can always do is, you know, just be in collaboration with your payers, who you're contracting with kind of these specific codes. I'm seeing that they are becoming a bit more, I guess, ubiquitous than they were a couple of years ago, but you know, reaching out directly to the source is definitely a good way to figure out, you know, how you can fund these different activities, who can bill for them, all of those types of specifics. But love that suggestion. You know, we'll try to customize things as much as we possibly can. You know, I just want to thank, of course, our regional LAN, as well as, you know, our subject matter experts. Thank you so much for joining us on this journey and helping us refine the process. I love the, you know, act small, think big kind of a consensus that everybody has seen. So, you know, just remember, you know, you're not going to have a full-fledged program right now. We just want to make sure that you have the tools and the breadcrumbs to be able to make the informed decisions when the time is ready for you all to kind of create these programs and start to engage your patients, their caregivers, and, you know, your providers and care team. There's plenty of opportunities for additional technical assistance. So if there's anything that, you know, we can do or something that you're looking for, don't hesitate to reach out to any of us at Mountain Pacific. And we'll make sure this recording gets sent out to everyone, as well as all of the supplemental information and resources that we included. So keep an ear and eye out for our affinity group that'll launch in the fall, as well as other Mountain Pacific learning events. But just want to say thank you so much for this 9-week period. It's certainly been a treat to engage with all of you. So thank you very much. Yeah. And I think with that, we are set to end. Oh, go ahead, Patty.
I just want a special shout out, Dr. Humphrey. Thank you for all of your contribution in the sessions as we went forward. And Joe Tabler, he actually called in on his vacation to share his expertise. So big round of applause for you guys. Thank you so much for taking the time, and it means so much to people who are just starting out. So thank you very much. And thank you all for your attention and your dedication to our presentations and our content. And we will look forward to hearing your feedback. So enjoy the rest of your day.
Yeah, Patty and Kristen, I just want to, you know, give my thanks for being included in this. You know, healthcare has gotten monetarized, you know, the focus on coding rather than the focus on patients. And I just recently got feedback from one of the clinics that it really, I mean, the successful programs nationally for SMBP that are large, that are involving several thousand patients, all are on capitation. You know, the concept of fee for service is hopefully going to be bypassed. Hopefully we'll have a more better system of compensating folks. But in looking towards the future, CPT coding has rewarded doctors, but certainly not patients. And secondly, is I'm certainly available on an individual basis. I've just recently retired, and health information technology and healthcare delivery is an area that I've got experience in. I was a medical director of HMSA, which is Blue Cross Blue Shield, for 22 years. I know the health systems. It looks like we are setting up, I'm setting up a presentation with Aloha Care, which is one of our Quest or Medicaid providers with them. It looks like the Medicaid is going to be paying for blood pressure cuffs here in Hawaii. It's a tedious thing, but I've used Mountain Pacific's name partly to get my foot in the door. But anyhow, yeah, and yeah, working with your other health plans, it often takes a doctor-to-doctor relationship and somebody knowledgeable. Now I've got a slide on that. So if you are looking for a content expert that can work with the medical directors at other health plans, why, I'd be glad to help you out on that.
Great. Well, thank you so much. And Joe, thanks for calling in on your vacation. We really appreciated it. And all of you, thank you for joining, and we will be in touch. So take care and enjoy the rest of your week.